So now we move to the panel discussion for the afternoon. We have 4 panelists, and now I must confess, I haven't met some of you, so it's going to be a great pleasure to meet you virtually online. So I'm joined by Dr. Rob Ellis, Professor Mark Midwinter, Associate Professor Dylan Laws, and at the 11th hour, I have to thank Dr. Andrea Henden for stepping in this afternoon at very, very short notice while on call to come and sit in for us. So Andrea, thank you very much. And you're here. Siok couldn't make it, but I'm sure you will be an outstanding panelist. So just a little bit of background before we get into this session. And I would invite any of you still online, and I hope there's lots of you, please pepper your questions through to Slido, and I will do my level best to ask those questions of our panelists. But this afternoon, we really want to discuss this idea of how you build a career in translational research, perspectives across the career stages. So in no order of age or trajectory, but as they're printed on my page, I'm just going to quickly bio each of our speakers. So we have Dr. Rob Ellis. So Rob, if you could put your camera on, that would be terrific. Rob's a trainee physician. He's an honorary lecturer in the School of Biomedical Sciences at the Faculty of Med at UQ. Completed his MD PhD in 2019, and a big interest in renal disease and renal function following nephrectomy. And it sounds like Rob's on call as well. Welcome, Rob. Professor Mark Midwinter, Deputy Head of School at the School of Biomedical Sciences and Professor of Clinical Anatomy at the University of Queensland. Been Deputy Director position at the NIHR, I presume that's in the UK, Surgical Reconstruction and Micro Research Centre, and a former Royal Navy surgeon. So lots of experience there, and I'm sure we'll get some more stories, as you say. Associate Professor Dylan Laws, welcome Dylan. Dylan's a psychiatrist at Caboolture Hospital and completed a Masters of Science in Psychology during his medical school, exploring how clinicians measure and communicate about risk. Another great seminar session we could have a separate thing on. But he's head of the mental health research group at the Critical Care Research, and he'll be speaking to us this afternoon. And then last but not least, Dr. Andrea Henden, hematologist, oncologist. I think, Andrea, I haven't got your details right in front of me, but I know who you are from QIMR Berghofer, and a translational scientist working in the area of hematology oncology. So, panelists, welcome. It's terrific to have you all here. What I thought I would do in the first minute or two is just get each of you to give a very brief introduction of why did you come into research when you've already got a clinical career. I'm going to throw that at Mark first, just because I can see you on my left-hand side on the panel. So, Mark, what got you into the sort of research side of things when you've got a rich and varied surgical career?
Because I wanted to know answers to questions that I was faced with clinically, that when looking at the literature, like we've just heard, there are obvious gaps and couldn't answer those questions. So then start thinking about, well, why can't we answer those questions? Now, some of those are not answered for very good reasons, but there are some pretty, in my area, which was mainly in trauma surgery, there is a paucity of evidence, and the answers aren't there because nobody's done the study. So that was really the driving force to answer real clinical problems.
I ask you, that must have been late after your specialty training, was that, or did this occur to you in medical school or in your basic training? When?
Yeah, no, that's important. I mean, I'd always been interested in research, and even as a medical student, was involved around research in different areas. Again, because I'm always asking questions and looking, but the sort of field of study changed as I went through training. Yeah, but the sort of growth into research was a long, slow burn from early days through the training period. Yeah.
We'll come back to you with some more insights shortly. So I'm going to throw to Dylan now, who's my next got you into research, and when were you aware that you were of that ilk that you would like to?
So for me, things all kind of happened a little bit backwards from most people. I went into my undergraduate studies with absolutely no career plan. And then I got my degree, was very happy about that, and realized that I had no plan for a job. And so I very quickly tried to find something that would put some food on the table. And the first kind of person that was prepared to pay me to do something that I had learned about in my degree was a clinician-scientist working in emergency medicine. So I'd done a double degree in music and psychology just out of interest. I'd learned a bit about doing statistics and how to do studies, and he was prepared to pay me $10 an hour to help him with some research. So I was doing that for a little while, and it was actually through doing that research at the very basic kind of research assistant level that I then got interested in medicine and applied for medicine, which is why I wound up halfway through a master's when I started medical school. So yeah, it's all a little bit backwards for me. The clinical interest came after the academic interest.
So that's the mercenary route into research. So, but look where it's led you. That's fantastic. Okay, we'll come back to you as well. Andrea. Journey, as they say, into research.
If that was the mercenary approach, I've taken the eternal student approach. So
Okay.
Did graduate medicine in Queensland, and I always knew that I had a real interest in medicine. Went through, did my internship, realised that I was probably going to be more interested in internal medicine, and my first JHO job was in haematology, and basically after I'd done that, I was hooked. Any other specialty I did, I was not nearly as interested in. And I think, so I'd committed to sort of haematology training and found that just such a fascinating sort of sphere, because it was really where immunotherapies were starting to be used. We were routinely treating our patients with monoclonal antibodies, and it had a major change in the outcomes for patients with lymphoma. So I think as I progressed through my specialty training, that's when I sort of really became interested in immunology and realised that, look, if I wanted to make a difference to my patients, look, I could do a good job for each of my individual patients that sit in front of me. But if I were to make bigger changes, then research was going to be the way that I could do that. And as I said, with sort of the background of the changing way that we thought about how we could treat cancer and using immunology and moving away from chemotherapy, that sort of became more and more interesting to me. So I finished my subspecialty training. I hadn't even quite graduated and got my consultant ticket and started a PhD. So I don't know that there's too many people who would choose that path. But I was lucky enough then from that time to combine both ongoing clinical work with my research, and that's really been, I found that extremely fulfilling. As I said, I think there are a lot of challenges in the way we treat cancer these days that are unacceptable, really. I'd love to see that we had therapies with less toxicity, therapies that were more effective, and that's really where my involvement in research comes from, just wanting to contribute to really making a change into the treatment options that we have.
Thank you. Okay, so Rob, you've you know what the question is. You.
I was a little bit like Dylan, actually. I started out in undergrad not really knowing what to do, so I decided to just do a as broad as possible approach. I did a Bachelor of Arts and Bachelor of Science at the start, and then I quickly realised that I didn't really want to do physics, which was what I initially started doing. So I went into biomedical science with an interest in that, and went down I probably want to get into medicine approach. When I was doing that, I saw that a lot of the things that were being taught were driven by research, and decided to get a little bit of a go in that. So I did an undergrad research project at UQ, which led to me doing my honours, and I did my honours over at TRI and saw all of the doctors in training try and juggle research at the same time as doing their jobs, which I decided I probably didn't want to try and start out research doing that. So I did my PhD at the same time as med school, which, looking back as a med reg now, I think was a wise decision, because I can say for a fact that I wouldn't be able to do a PhD now. So,
That's actually a perfect.
But
So I'll let each of you address this actually. A couple of questions dealing with the timing of PhDs. So the question is framed around, do you feel like you did your PhD at the right time? Or would you, if you had your life over again, would you change it and do it at a different time? Or would you not do it at all? So I'll start with Rob. I'll just go backwards in the reverse order. So Rob, did you do it at the right time? And would you do it again?
So David, you know, as I said, I was fortunate enough to be working in an environment where I saw people juggling both PhDs in isolation and PhDs at the same time as working in medicine. And I don't, you know, I may have taken a different approach if I didn't see that early on, but that was what drove me to do it when I was doing med school. And I think it was the right choice, just looking, you know, back, because being a junior doctor, it's hard to actually find time to do anything else apart from work. And you know, I had the interest back when I started, and that may not have carried through if I'd just jumped straight into work, because just out of necessity, I wouldn't have had the time to think about it. I think I'm happy with my approach. I wouldn't change a thing.
Andrea, you're expressing misgivings by
personal misgivings, purely because, as I said, my interest in research really came from my training in haematology. So for me, there wouldn't, you know, didn't actually know anyone when I was in medical school who was a you know, working clinician-scientist. I didn't sort of have any real role models to talk to about possibilities there. But I agree that I think the competing interests, certainly when, particularly in sort of more junior training and when you're first sort of starting to you know, be more independent clinician, you know, that is a big sort of mental challenge. And the concept, I think, of starting a PhD in that environment, like Rob said, is quite difficult. As I said, I delayed it till after I'd finished all of my specialty training, and I think that's allowed me to continue my research now in a model that does combine ongoing clinical practice and research. But equally, I think if I knew this is where I wanted to get to, I probably would have liked to start my research a bit earlier, maybe done an MD PhD.
So there's a question for you specifically, Andrea, about the fact that you have done your PhD after your registrar fellowship training has finished. Has that affected your clinical career by having to do research when you could be building a practice or a clinical?
Look, I've kept my clinical practice in the public hospital system. So in terms of building a practice, I don't have some of the same you know, need to be out there promoting, finding referral bases and things that I think some junior clinician, you know, junior consultants really do need to spend a significant amount of time on. Equally, I think the reality for a lot of junior doctors these days is when they finish their specialty training, they're probably not going to walk into a full-time job somewhere. There's a lot of people who will have to do maybe a combination of some public and some private, or you know, they'll be working on building a private practice. So for me, actually, that was a good time to because equally, I think, you know, as I said, it's not as though I turned down a full-time clinical job in order to pursue my research. I think that and equally, I've been able now to sort of craft my practice into you know, most of my research is in transplant immunology, and so I care for a lot of transplant patients now, and so my clinical practice and my research are really closely intertwined, and I think you know, has been quite complementary with the clinical and the research components.
Just for courses, that sounds great. Okay, Dylan, so for yourself, PhD and the order in which you did it.
The answer is yes, but I do have some comments I can make about my experience. I wound up...
Remind us when you did your PhD exactly in relation to, yeah.
I started my PhD in my last year of medical school. And that was, the way that came about was that I'd been publishing all the way through, finished my master's and just kind of kept going. And my wife actually emailed Diane Ely from University of Queensland behind my back when one of those papers wound up in the Lancet, And she emailed saying, look, you're doing all this research, you might as well get a qualification for it. And I was like, well, that makes sense. So
Fine now, just so you know, so you can do a shout out and say thank you. There you go.
thank you very much for that, Di. You've certainly had a big influence on my career since. So I go on and I finish this PhD. And there was one really big advantage of that, because it forced me to look at how I juggled the academic load and the clinical load at a time when that was quite manageable. And so I built some of those kind of time efficiency skills at that point. And it also meant at a time when other people were a bit nervous about what specialty they wanted to do, and some of them are quite popular, and how am I going to, look ahead of the pack in other ways. I came out of medical school with 10 papers published, and that kind of, I felt, gave me some freedom to be able to choose based on what I wanted to do. And that's kind of where the challenge of doing your PhD that early also comes from, because when I got out of medical school and did my rotations, what I discovered is that I actually really enjoyed psychiatry. And I had done my PhD in chest pain. And I had built all of these research connections amongst cardiologists and emergency physicians. And so that left me with a very challenging decision. Do I follow where my kind of clinical heart is taking me? And am I going to have to give away everything that's happened up to this point? Do I get to carry that across? And I eventually decided that what I was going to do was to push on, go into psychiatry, and then work out how to kind of pivot my academic career to better line up with my new clinical focus. And so that's worked out actually relatively well, because what you learn in a PhD isn't just one particular area of study, but you learn about a way of doing a particular kind of research, and that methodological expertise does carry with you. And that's why I've kind of now am doing research looking at mental illness with concurrent critical illness, so recovering from post-intensive care syndrome and things like that. So it's actually worked out for me very well, and it meant by the time I got to doing my exams for psychiatry and that kind of thing, the PhD was behind me. The other thing I think is important to think about, though, is when you finish your PhD, a lot of the major grants that you're going to be wanting to apply for also have timeframes on them. So, for example, some of the NHMRC grants want to know, are you 5 years post-PhD, 10 years post-PhD? And they line you up with other people at that level. So you need to think about, what am I going to be doing after my PhD? And how's that going to line up with when I'm going to be applying for grants if I'm going to continue building this academic trajectory?
Okay, there's some real world advice from someone who's obviously competing in the grant system. So thanks, Dylan, for that. Mark, to you, sorry to come to you last, but
fine. That was very interesting to hear others' experiences. Well, first of all, I should say I started my academic career and clinical career in the UK. The system's somewhat different. My is not a PhD; it's a MD by research, which actually, as a medical graduate, particular institution I was at, University of Newcastle, that is what you did. You didn't register for a PhD. It was, if you're a medical graduate, MBBS, your research was an MD by research. But anyway, otherwise it's very much similar. I did it once qualified, and during my training. I wouldn't necessarily recommend that. The coincidence of trying to write up my research and sit my fellowship exams in surgery was domestically challenging, should I say. But there was good reasons. And I think it depends a little bit what your research area is. My research was very interventional on patients. So you really had to be a professionally qualified to do it. I was doing endoscopic ultrasound and guided biopsies of pancreatic lesions. And so, that's not something, unless you got...
student, you can't sort of just lob in and do that. No.
So there was a necessity, and that's really why I was offered the opportunity, to be honest, that I could do it. And it was something that could become within my skill set. So, but having said that, I've sort of now shifted in that I'm now doing very much laboratory research and supervising higher degree students doing research within a laboratory, including some MD PhDs. And I think it sets them up fantastically for a clinical academic career, with some caveats. And this is where I see a great contrast between Europe and Australasia, is that people who do an MD, PhD with an interest in clinical academia, there enter a clinical academic training pathway that gives them protected time during their training to continue postdoctoral studies. And I think that's really important. That's the only thing I think is difficult in Australasia. Once they have the MD, PhD, and then going to clinical training, is finding that space during specialty training to continue with postdoctoral studies.
Well, Mark, that's a perfect segue into some of the questions that are coming through online, is about balance. How do you balance time between your research activities, your research-focused activities, and your clinical-focused activities? And I'll swing backwards and forwards across the panel, but just really briefly, how much time at this point in your career is spent on clinical activities as a proportion, 10%, 20%, and how much is spent on non-clinical research activities? If you just give me a quick ballpark, and I'll whip across the panel so we get a feel.
It's easy for mine because I'm sort of at the other end of the sort of career spectrum. So I'm full-time academic, both teaching and research.
Okay, and so if I ask you to look back 10 years ago or 15 years ago?
10 years ago, I was about 80% clinical, 20% academic, I suppose. Yep. No, perhaps 70-30. Okay. But the clinical always takes precedence, doesn't it? So if the patient's acutely ill or needs to go back to theatre, then I'm not going to go to the lab and finish an experiment. I'll take the patient back. Surely.
Okay. So Dylan, what's your split, clinical and research currently in your current role?
So currently I'm 60% clinical, 40% research. When I was a registrar, it varied depending on what rotation I was on. If there was research support, I might get 1 day a week or a couple of days a week. And as a resident and as a medical student, it was basically holidays, rostered days off, that kind of thing, using those efficiently.
Yep. Okay. Rob, what's your split?
It's pretty dismal at the moment, mostly clinical, and again, sort of roster days off, afternoons and that sort of thing for research. But I will sort of mention that I did get a 3-month secondment over in public health during when all the COVID stuff happened. So that was actually quite an interesting experience for me, because I was able to explore a lot of research and data sort of thing as part of my actual day job. So I was able to incorporate a lot of that into my work, and it was almost 50-50 if I look at research outputs there. So yeah, it's very much dependent on where you work, where I've been working and what job I'm doing. So no good answer, and
okay,
not great. It's
okay. Andrea.
So at the moment I'm 0.4 clinical and 0.6 research. And when I started my PhD, it was more sort of 0.8 research, 0.2 clinical. So that sort of has just come a bit towards the mean a bit more since.
And so how did you make that work? What was how did you get the funding, or what was your pathway to getting protected time?
So I suppose I said, so I'd finished my specialty training. I basically started my consultant job. There was a 0.2, FTE available. So I started that, and I got a, standard PhD scholarship. So obviously that's the other thing no one's talked about, obviously the financial impact of choosing a research career. I think my husband would have liked it if I went into private haematology.
Sure, the vow of poverty.
But yeah, yep. So I have sort of, as I said, because I think that's one of the, although it's sort of awkward to have been, I'm a 42-year-old early career researcher. I think it does at least allow that I've sort of built my consultant career with that protected research time in it, and obviously it's up to me to find funding to, you know, from the research sphere, but at least I know I've got that sort of 0.4 that's more certain.
Yeah. Okay, so to explore this a bit more, there's been a few questions on a similar theme here about after you've done your research training and your specialist training, what opportunities are there for people employment-wise? How do you get a consultant job that also has clinical and research time attached to it? Anyone can speak to this now. I'll open it up to our panel. Dylan, you look like you're moving your mouse, so why don't you start off?
Well, I can tell you how I've got my protected research time at the moment. Metro North Hospital Health Service has this wonderful clinician research fellowship that people can apply for. It's not just open to doctors, it's open to all clinicians. And it provides 0.4 protected research time for several years. And then your final year, you get 0.2 FTE in order to conduct a program of research. So you get this kind of window of time where you get to build a body of research. And it's important to continue looking for what you're going to do next if you want to continue to have a clinician-scientist career. So looking for NHMRC grants, NRFF grants, and things like that.
So, and just for people maybe outside of Queensland, Metro North is one of the health services. It's a big metropolitan health service in Brisbane's northern suburbs, extending up near to the Sunshine Coast. But they have a sort of a fellowship program or a sponsored research program. I'm not aware that other health services do that. I believe Sunshine Coast is starting to do something similar, but
I was just going to say I'm on that. I have that. I was on the year one of that fellowship this year as well, and they were speaking the other day that Metro North's the only health service to have a similar fellowship at the moment. So
yeah, which is a great, means it'll be a destination for people who are considering a clinical scientist career. Metro North might power up. Mark or Rob, did you have any addition to that about the pathways for people once they get their specialty ticket and their research ticket?
Yeah, I mean, as I was intimating, I was fortunate because there is a structure within the sort of universities and National Health Service within the UK, and there's similar structures in the rest of Europe where there are clinical academic pathways. So they are funded pathways within a National Health Service where they're associated with usually an academic institution, such as a university, and co-fund positions. So I was lucky enough to get one of those. So.
Okay, thank you for that.
I think that'd be something fascinating to discuss, the landscape in Australasia, because I have an interest in developing our MD PhDs and finding a pathway beyond that.
Yeah, I think there's a concern that I can see in some of the online chat here about the resource that we put into building clinician scientists, and yet we don't provide any supports for them once they're out in the big bad world. And it seems like a lost opportunity, really. It shouldn't be so tough. But so, given that it is tough, what skills can people acquire to help them succeed? So I'm thinking beyond just the clinical and the research skills, are there particular time management or writing or leadership skills or courses or things that you've learned along the way, even mentorship? So I can see Mark nodding. Mark, maybe I'll throw to you quickly while others gather their thoughts.
I mean, there's the obvious research skills and intellectual skills, but I think you pointed out one that's really important, writing. That's probably quite specific. I think communication. You've got to be able to communicate your idea. People have got to feel the passion and understand what your direction is and what your impact could be. I think
excellent, thank you.
Generally.
Dylan, you've got a finger over the mouse, so fingers on buzzers. Yep.
I think a really important one, certainly time efficiency and time management. And it's amazing how, with a little bit of thought, a really onerous and time-consuming task can become quite quick. I can give you an example where I had 10,000 test tube specimens in a freezer, 2,000 of them were going to wind up in the study. 1,000 of them we needed to keep for a future study, and the rest were useless. And to sort through them, I needed to bring them out of the freezer, go through, work out which is which, and get them back in the freezer within 10 minutes. And I had a really good think, there must be a better way to do this. And I put all of the unique identifiers into an Excel spreadsheet, unplugged the keyboard, plugged in a barcode scanner, and then put conditional formatting into Excel so that green was in the study, orange was to keep for later, and red was to go. And I managed to get through it in a couple of hours. So
Fantastic.
what looks like it will be months of work with just a bit of thinking can actually be quite efficient. And there's a lot of research that's like that. We're actually just taking I think it was Abraham Lincoln said, if you've got 8 hours to cut down a tree, spend 6 sharpening the axe.
Yeah.
The other skill I just wanted to mention is really important is interpersonal skills, because research is not a solo effort, it's always a team effort. So being able to build those relationships within the academic community, that's something that I think is really important to start early, because they're the people who can help you with whatever else is going on.
Thank you. And I'll have to get you to teach me how to put a barcode scanner on my keyboard later. I'll send you an email. Rob or Andrea, any particular insights from skills or things you want to confirm or express support for?
I was just going to say, look, persistence and resilience. I know they're words, particularly. I think resilience gets talked about a lot, but I think in combining any 2 careers, you're probably going to have twice the challenges in some ways. So just being able to have some perspective on those, and just to really, I've found mentorship to be really important. I think clinician researchers, there's a lot of really good independent thinkers, but in fact there's always more than one way to skin a cat, a bit like the barcode example. So having people you can talk to and bounce ideas off, and just sort of maybe give yourself a bit of a filter for your own thinking as well is a really good thing. And as you say about team building, having good people around you, you'll learn so much from them.
I'll come back to that question of mentoring, but Rob, just any skills that you think that you wish you had, or that you would advise others thinking about a career in research to acquire?
Yeah, I would say it comes back to the time management type of thing, but my advice would be learn the basics well. So things like writing, statistics, data analysis, and literature search. If you learn how to do that efficiently and effectively, then that cuts down your work and your time and everything else. And if you have limited time, which I think most of us do, working clinically, then if you can do the basic things right, it doesn't take much more to learn something a little bit extra on top of that. Taking a basic statistical test, for example, and learning how to do it a more complicated analysis. It's not going to take much longer if you already have that solid groundwork. So when you're doing your training, just learn how to do basic things, essentially, and then you can build on that. I think that's the main takeaway.
So thank you. So a few people today have mentioned the word mentoring, and I know personally that I've found that incredibly important for my own career. I might just ask each of you your thoughts on mentoring. Some people advocate having a single mentor throughout your career. Others talk about a team of mentors. I'd just be interested in your reflections. Some people say I've never needed a mentor. So there's no one way to do these things, but I'd be very interested to hear from the panel about their experiences of mentorship and what you would look for in a good mentor. So maybe Mark, I'll start with you.
Yeah, I think it's very important. I've been very fortunate in having different mentors at different times. And I mean, I suppose the early stages, this was really just people that found inspirational, or you could go to and knew that they'd listen carefully and respond when you're having problems, either specifically around the area of research, but actually more general, how am I going to manage this difficult sort of clinical position where I'm not getting enough time, that they have the insight into how best to approach those things. So I very much think you should seek out mentors. but I don't think necessarily there needs to be one person for your career. You might outlive them if I'm mentoring anyone. Actually, you can have different mentors at different times, and even plural at the same time. I think is sometimes very helpful because people have different skill sets. So, you go to someone for a research-focused problem, but someone else that's might be, I don't know, something more logistical gifted.
Thank you. Dylan.
Yeah, I think mentorship's essential. I was very lucky with my early mentors. Dr. Martin Tan was an emergency physician in Christchurch Public Hospital, and Dr. Louise Cullen at Royal Brisbane Women's Hospital were wonderful mentors during my master's and then my PhD. And because of that change in career trajectory and that shift in research, I wound up losing those mentors because my new research interests didn't really align with their own programs of research. And so I wound up having to find new relationships, which has its advantages and its disadvantages. But one of the great things about working with a diverse range of people is the fact that they have different personalities, different strengths, different approaches, and you do get to learn what each person does that you like and want to emulate, and things that maybe they do that you don't want to emulate. And ultimately, I think it does make you a better researcher. But as I say, it's relationships all the way through. I don't think you ever get to a point where you're not in some kind of mentorship relationship.
Thank you. Andrea, mentors, you mentioned this specifically, so clearly it's important to you.
I think I realize it's important because, as I said, I didn't have a good clinician. I didn't know a clinician scientist as a mentor or even as a role model when I was in medical school. So I think it's been really important for me just to I think there's role models and there's mentors and there's different things that they'll bring to you. So they're people that you can sort of just look at their career choices and trajectory and maybe their productivity or their area of research and sort of get sort of advice by proxy, I suppose, if you like. But equally, I think it's good to have a mentor, someone who you can maybe talk about more more personal things that, as you say, things about your own work-life balance or maybe a particular problem as it relates to your research question or your clinical practice. And so it's good, as Dylan said, they probably will need to be a bit discipline specific as well. So, but equally, you're probably going to run into a number of those people and benefit from having a number of mentors at different stages of your career.
Yeah, I think one thing I've found is mentors can help you think strategically. I think they can often help you think beyond the immediate problem now and say, let's start planning. Where are you going with this? What does next year look like, and what are you putting in place for 5 years' time? Where do you want to end up, and how are we going to get there? And they won't have the answer, but they'll ask the question of you and make you think, and then you can talk to other people about plotting your course to get from A to B. Rob, I haven't given you a chance to express any views about mentoring.
I am also very much of the opinion that it takes a lot of different personalities and a lot of different groups of people to help when you're working in a clinical and an academic joint sort of role. I probably set some records. I think I had 6 PhD advisors for one of those reasons. Everyone brought a different sort of mindset to the table and challenged, my approaches in different ways. And so I've taken that on and moving forward. That's really how I go about both my clinical life as well as my ongoing research when I have the time to do it. So I think out of necessity, you need to have the more the merrier sort of approach, but definitely essential, I would say.
Okay, now I'm aware that we are getting close to time here, and I'm trying to keep on top of the questions that are coming in. One thing I think that all clinician scientists face is barriers. During your career, there are difficulties and challenges you have to overcome. So what would be the main barriers that you have identified in your career, and how did you overcome them? What tips have you got for dealing with these sort of setbacks that befall us all? So maybe Andrea or whoever would like to start with overcoming barriers. What are they and how do you do it?
Look, the biggest barrier I face at the moment is I think the funding barrier. You know, as I said, I'm lucky to have, you know, my clinical portion of my job, you know, is a permanent public health position, but, you know, funding your independent research career is a big barrier. You know, once you sort of get out of your PhD, you're probably already having to think about that. You know, you need to think about how you're going to fund your salary, and it's just such an enormously competitive environment at the moment. So that probably is my biggest barrier, and I don't have an answer about how to overcome it because I wouldn't say I have yet. I think the other barrier is really just combining 2 careers and a family life as well. I think that's a reality for a lot of clinician researchers. We have you know, there's life outside work and the demands that you might have there as well. So far, I wouldn't feel that I've had, I feel I've had more opportunity than true barriers for planning my career, but equally that doesn't mean it's not a challenge even when there's a reasonable amount of opportunity. I'm not sure.
No, thank you. I mean, funding and time and life are barriers, and people address them in different ways. Mark, Dylan, or Rob, did you want to address the issue of barriers in a career?
Yeah, I mean, they're all the common barriers, aren't they? I think, and Dylan put his finger on it in that you have to have a strategic think about how you juggle particularly time and efficiencies, because even the sort of funding, one of the things I still find quite a barrier is the time it takes to develop a good grant application. Now that's an investment of time that you'd never know whether that investment's going to pay off. Hopefully they will, even if it requires a few rewrites. But I think trying to do that efficiently and effectively is important, but yeah, it's time and money, isn't it? And also then there's the other thing is the physical resources, make sure you're in the right institution to get those results, you know, that you've got either the being able to recruit or analyze samples or wherever it be. So being careful about choosing the institution with the appropriate infrastructure to support you.
Good advice. Dylan or Rob?
Yeah, so just building on the challenges of funding, one thing that bothers me a little bit about the current way that this stuff is set up is the fact that grants are competitive, and yet when you look at what good research comes from, it's collaboration. And so finding a way to be able to make sure that you get the longevity and the time to do the work that you want to do, but remembering that you're not actually competing with the other guy. You want them to get a grant too. And if they've got a great idea, that's not a threat. That's great. You should work with them. Other people working in your area, that's great. So just trying to keep that competitive angle of finding grants and that kind of thing from actually creeping into the research. Because the more of us that are talking and sharing ideas and all of that, you know, everybody wins. The other challenge is you're essentially doing 2 jobs. It's almost like you've dual trained. And so you're working with 2 different groups of people who don't fully understand what you do with the other half of your time, which means that they're not that well equipped to be able to help you or enable you or even provide that kind of emotional support. You know, clinical staff don't really get how stressful research can be. And researchers don't understand just how important it is when a patient needs your time. You're not going to make the Zoom meeting. And so you can feel a little bit alone sometimes in that. So I think it's really important to make sure that you get the support from other clinician scientists who understand that tightrope that you're often walking.
Okay, so teamwork and collaboration, good points there. Rob, anything you'd like to add there about barriers and how to overcome them?
Yeah, I mean, it's all the same theme, really. Time and money being the main things, but I think something that comes out of it, which I've been trying to sort of manage myself this year, is when to, you know, say yes and say no to things, because different opportunities come at different times, and often they're aimed at people who are working solely in either research or clinical work, and often, or when you're balancing two different things, you may not be able to accept something, even if it's a great opportunity, just because you won't be able to juggle it with everything else. So I think becoming more further into my career, although only at the start, that's something I'm starting to find, is that you need to take, pick and choose what you decide to commit your time to, I suppose.
Mm. Well, yeah, and I guess that fits in with strategic thinking, doesn't it? About how does this fit into the overall plan, and am I going to commit time and resources to this thing or some other thing? So that underscores that nicely. Now we are about to wrap up, so I just wanted to leave each panelist with a question, a simple question, really. But what are your final tips for someone who might be hesitating as to whether they really want to embark on a career in research alongside their clinical career? What tips would you give to them to reassure them that it's a sane decision to make and is achievable? I know that might be a lot to ask, but any quick tips for people about how to survive and succeed in a career of clinical science?
I would say find something you love. It's hard work doing both, but if you really, if you're excited to read a new article, if you can't wait to see your research in action, you'll be able to do it if you really love it. Okay,
passion, good. Mark.
That's the word I've used before, passion, I think. There's sort of passion in both areas, because I think we're talking about clinical academia, and one feeds off the other. You have a passion for your discipline, looking after these patients. They throw out questions that drives the passion for research, and then you can't wait to say, how's this going to translate? How's this going to make my patients that I care about better? I think that's
very good. Dylan or Rob, anything to embellish or add to close it out?
I think that it's important to remember that research is high effort but high return. I published one of the papers from my PhD in 2014. It was a chest pain algorithm that allowed people to go home a few hours earlier. And in 2017, I had a look back to see what had happened since. And it was being used in one hospital that I knew of. And I looked at how many patients had gone home earlier, and it was thousands. So when I ran the numbers, the amount of extra work that had allowed to happen at that hospital was more hours than I'll do in my entire clinical career. And that was one idea I had as a medical student. So it took a lot of work, but the payoff is phenomenal. So it's really worth sticking it out. And if you have a good idea, there's a good chance it could really make a big difference.
Inspirational. Okay, Rob.
Yeah, I mean, look, if you're interested, just do it, because it's not going to do you any harm. Even if doing research and trying to publish a paper is the worst thing you've ever done and you never want to do it again, having that on your CV is going to help you further on in your career. So if you give it a go and you don't like it, you've learned something, you've got something out of it, and you're going to be able to move on with your life, not wandering. I think that's the way you just have to approach these things if you're not sure.
Thank you. Okay, well, I'm sorry that we've had to draw this panel discussion to a close, and in fact, draw the entire day to a close. I particularly want to thank on our panel, Mark, Dylan, Rob and Andrea, particularly Andrea for coming in at the 11th hour. We're very grateful to all of you for giving up your Saturday afternoon.